Hello, sir. Hi, hi. Who are you? Oh, sir, I'm SLE by the way. Systemic Lupus Erythematosus, that autoimmune disorder involving multiple organs and forming an auto antibody, especially against nuclear antigens that I basically cause disease by depositing the immune complexes in the cells and tissue and damaging that organ. And sometimes I make specific antibodies against certain specific cells. So now you got that. So what are you doing here, bro? Sir, you don't know. There are two patients in your ward suffering with SLE, so just came to visit them. Yeah, actually, I was just thinking that how do you came here? Means, by which route you came? What is the pathogenesis of SLE basically? Sir, don't panic. Let me explain my pathogenesis to you. There are three factors, sir. First is genetic factor. The second one is the immunologic factor, and third one is the environmental factor. As you can see, the genetic factors are basically a mutated HLA-DQ gene leads to the production of anti-double-stranded DNA antibodies, anti-Smith antibody, anti-phospholipid antibodies. So that is the reason of me being coming to your ward. The second reason is that there might be deficiency of complement proteins such as C1q, C2, C4, which basically helps in phagocytosis of the damaged apoptotic cell nuclei, and the deficiency of them might lead to the accumulation of damaged nuclear antigen that may elicit the immune response. Sir, the immunologic factor is basically the failure of the self-tolerance of B and T cells. Sir, tell me what I can do in this. It is your problem, no? It is a problem of your body that your T and B cells are basically not self-tolerance towards their own antigen. Now, if they are betraying you, then how I can not betray, sir? Sir, lastly, I am telling you that the environmental factor is the chronic exposure of UV rays, which induce the apoptosis and damage the DNA. Now, if he is doing, I will come, sir. And next is the female preponderance, because, sir, I love estrogen and estrogen loves me. So where there will be estrogen, I will come, sir. So I must tell that females who are on the estrogen containing oral contraceptive pills should aware of SLE. Sir, how will you identify your two patients of SLE? Do you know the criteria for classification of SLE? I forgot about that. Can you please tell me what are your criteria of classification, dear SLE? First, chronic persistent fever of unknown origin. Second, malar rash over the face, neck or back. Third, non-scarring alopecia or thinning of the hairs. Fourth, oral or nasopharyngeal ulcers, aphthous ulcers. Fifth, non-deforming joint pain in two or more peripheral joints. Sixth, auscultate for pleural effusion or pleuritis. Check for the signs of peripheral neuropathy such as wrist drop or foot drop or atrophy of the thenar and hypothenar muscles. Eighth, check for the renal cause such as persistent proteinuria. Ninth, about the hematological signs of anemia, splenomegaly, lymphopenia, thrombocytopenia. All this suggest SLE. Let us discuss about the immunological lab diagnosis of SLE. So first we have to check the anti-nuclear antibodies. If they are positive, then it is SLE. Then we have to check about anti-double-stranded DNA antibodies. Then we have to check about the anti-Smith antigen that is specific for SLE. Then we have to check about the anti-histone antibodies, which are suggestive of drug-induced lupus. Now the drugs which cause lupus are hydralazine, procainamide, isoniazid, chlorpromazine, etc. Then anti-Rho antibodies must be checked in pregnant female, because presence of anti-RO antibodies is related with the fetal heart diseases, so that must be kept in mind. Coming to the management, non-life threatening conditions are managed with analgesics and anti-malarial such as hydroxychloroquine. The dose ranges between 200 to 400 milligram per day, that is once a day given. The NSAIDs are used as analgesic and their dose is the higher limit of their recommended dose. Then in some situation, if the patient is worsening in the condition, low dose glucocorticoids are also administered, such as 0.5 milligram per kg per day. The life threatening situation are managed with a high dose of glucocorticoid, that is 1 milligram per kg per day, along with a second agent that may be mycophenolate mofetil, or there can be cyclophosphamide. Thank you.